Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. So, welcome everybody. This is Josh and Adam. We are coming to you not quite live on August 10th, 2023.
What do you mean not quite live?
Well, we're live, but they're going to be listening to this. I mean, my turnaround times have been pretty good, but lately they're slipping. So they'll probably listen either late tonight or Friday. Something like that. I just need more hours in the day. That's what it comes down to. It's like, or we just need a producer. We need a producer is what we need. That's the thing. Just do our little chat, our little spiel, and then be like, okay, peace out. Producer's going to take it from here. And then it just magically appears on the interwebs later. One day when we're rich and famous, that's what we'll do.
Yeah, so anyone who's a producer, we're taking applications. We won't pay you because we don't make any money from this, but...
Internship. Yeah. No, it's an internship.
Yeah. Yeah.
Great experience.
Yeah, so if anyone is in like undergrad, communications major, wants some credit, we can try and sign your paperwork for you, so...
Yeah, if you were a communication major, but are randomly listening to medical evidence science podcasts, then yeah, this job is for you.
Well, maybe they're into medical media.
There we go. Yep. And if you are in that field, we need to talk to you because we still need to find a medical journalist or a science journalist to track down and interrogate, etc. Okay, so today we had two topics we wanted to talk to you about. One was med shaming, which Adam suggested, which I thought was a neat idea. And then the other one is the mind diet, which is this really fascinating study. Adam's going to give us the details about it on cognitive decline and dementia, and can diet prevent that? So lots of fun stuff to talk about today. Should we jump in and do our segment on med shaming first? What do you think, Adam?
Yeah, let's talk about that.
Okay. Oh, wait. Okay, so you know how I'm like trying to learn how to be a better podcaster and like all this stuff. And so one of the things I was reading is apparently people have to like us as human beings to like be engaged and listen to us. And one way to do that is to like share a little bit about ourselves. And so we could give a little tidbit about who we are every episode. Sort of like you would probably never know this about Adam. So Adam, quick, briefly, what is something crazy people wouldn't guess about you that's true?
And recording live from my psychiatrist's office.
Relax back on the sofa. Tell us about your childhood.
Yes, talk to me, Freud. What was the question again? Sorry.
Yeah, I think that's Adam's gentle way of saying move on, Josh. All right, we're gonna move on.
No, seriously.
Yeah.
No, that was a sincere question. I actually
forgot.
It
was. I don't know. I think it'd be fun. I mean, I consume like the heck out of podcasts, and I get like connected to the podcasters and curious about them and such. So anyway, yeah, tell us a little bit about you, something that someone wouldn't necessarily guess, like an interest or something that they're like, oh, you're not doing research articles all the time. What else do you do?
I think something that's super quirky about me is like I'm an absolute neat freak. Like I need everything to be like, like organized. Huh. My apartment like always has to be spotless. Like I do not like anything messy. Like my clothes are like organized in my closet by like color and like style.
Wow.
It's like very good. I don't like it when it's like shifted. I don't have a diagnosis of OCD.
Well, it's a spectrum.
But I have OCD tendencies of like, I won't like, wash my hand 10 times before I leave, but like, if I see something out of place, I will put it back and then kind of like fall down this like ADD train of like then like deep cleaning my
Oh.
entire apartment. And it's like, I don't know if it's an anxiety relief type of thing or what, but I don't know. That's just like a little quirky, weird thing
I
about
would
me.
not
It's
have
like
guessed that. I would not
very
have guessed
like
that at all.
orderly. Yeah.
That is interesting. I am literally the complete opposite. So I pick out the zoom range of my video, like that you can see right now, and that's the only part of the office that's clean. Everything else is like a total disaster. And
Well, you
that's
also
just
have
the
a
way.
kid.
What's that?
You also have a kid.
No, this is my office.
Oh,
Like, yeah, it's I mean, it's true. He comes in here and ransacks it sometimes, but you can barely tell the difference. I mean, it's just like you were talking
is
about
this
your
like a
clothes by.
beautiful mind? You just have like papers everywhere and like formulas going
I mean, I'm
everywhere. You
even
have like,
embarrassed. I mean, okay, it's like full. I'll just share. Like,
oh
it's
yeah,
just like total chaos.
oh yeah.
There's
No.
like, yeah. Um, thank God this is just audio for the viewers. So you were talking about like your clothes in like color order. All my clothes are on my bench press table, and like it's just a freaking disaster. And I've been that way my whole life. And in college, my poor roommates, right? So my college roommate could not stand this because he wasn't as strict as you, but he was pretty clean. And he's like, you know what? I'm going to do an experiment one day. I'm going to put a fork in Josh's bed. I don't think he's going to notice. I think he's going to sleep in there and not even know. And he totally did. And I didn't know. And he's like, you know what, Josh? Your room is such a shit show. Such a mess that like you didn't even realize I put a fork in your bed. So that's what you're dealing with here. So the complete opposite. So dear listeners, of course, this has nothing to do with anything, but now you know a little bit more. We are the yin and yang of cleanliness, I suppose. Now, let's move on. That was good. I think our listeners know a little bit more about us now. All right, so let's talk about med shaming. How do we even define what that is?
In my opinion, med shaming is either it's usually not so much from the medical field onto the patient, but at least that hasn't been my experience. I feel like
Mm-hmm.
with anything as medical providers, we kind of do too much prescribing at times, or just like we put people on medication, but always forget about like, okay, when are we coming off of them? When are we tapering them? We have adequate control of something, like can it be controlled now without the medication, or is this something that nope, we have it under control, it took us forever to get here, we should really just kind of stay on this medication
Mm-hmm.
because it's helping so much. And so, at least in the field of geriatrics, we kind of see like, hey, we have people who are elderly at risk of falls, lots of side effects of certain medications, and so if we keep piling on medications, that could be problematic, and so we should probably start to pull away.
Mm-hmm.
However, what I see a lot is patients or family members or the media or just kind of like the cultural, what seems to be like the culture in the health and wellness sort of field is like, if you're on any medication for anything, you're an abject failure and like shame on you. And
Oh
it's
yeah,
really, really
yeah.
not okay. It's not cool. You
From a
see some.
patient's perspective or a provider perspective or both?
I mean, I think both, right? I think as providers, we
Yeah.
need to provide what is medically necessary and not overdo it or underdo it on certain things. I think, like just because someone, let's say, is overweight doesn't mean they have to be put on Ozempic, right?
Mm-hmm.
Um, and then conversely, if someone's diabetes is so well controlled, they don't also need to be on four different medications perhaps, and maybe you can talk about like, okay, hey, things are looking really, really good, let's kind of take off on medication so we don't get your sugar so low that you pass out or something like that. But from a patient perspective, what I'm seeing is a lot of patients, or not a lot of patients, but just patients in general being like, oh, that's a lot of medications, or I don't really, especially in the field of weight loss, they feel like if they're on a weight loss medication that they're a failure, and they're
Mm-hmm.
not. A lot of
Right.
times, like you're doing the thing, you are eating well, you're exercising, but it comes to a point where like we're not making much progress, and we just need a little bit
Yeah.
more help. And that's what the medication is there for, as long as it's being prescribed and monitored safely. Like that's okay. I also see it the same thing sort of in when it comes to mental health. A lot of people who have like an actual diagnosis of ADHD and aren't self-diagnosing or whatnot, like have an actual formal diagnosis and have completed the workup, a lot of the times just kind of want to push through it and be like, no, this is a me issue. I want to sort of have a healthier sort of like an environment to support my ADHD needs. I need to just kind of use my willpower. And like,
Right.
yeah, to an extent that can help, but also these medications are very helpful and can, like, from a functionality standpoint, really significantly improve your life for the better. And we've developed these medications for a purpose, and you shouldn't be shamed for it, especially like in the naturopathic field too. Like, just because you're getting placed on a blood pressure medication or a statin or aspirin or clopidogrel or any of these like medications from primary secondary prevention standpoint for, let's say, cardiovascular disease, it's these medications again are being developed for a specific reason, and should be used appropriately when they're being used. And you shouldn't be shamed for being on medication. Some people genetically have higher predispositions for, let's say, for cholesterol, and you can eat the healthiest diet, exercise like a maniac, get the best sleep, have absolutely no stress, love your life, and still have issues that put you at higher risk for cardiovascular disease. And you shouldn't be put to shame for being on these medications. And for people who have like depression or anxiety, there should not be shame or blame for your mental health. Like, these medications are there to help you get through that. And like, yeah, counseling helps, medication help. The two together seem to work better than either alone. And like, we should take um, take advantage of modern day medicine. Medicine is going to always evolve, and to kind of put a contrarian view to it just because people are viewing it as quote unquote unhealthy to be on a medication, or like there's something wrong with you, I think is really detrimental to society, and it really just needs to stop, especially in the
Mhm.
health and wellness field where it's so prevalent.
Yeah. Yeah, I think that's spot on. And you know, I think a lot of, I mean, I don't know that I've experienced like shaming from other people towards my patients, or other providers towards me as a provider, that I like will recommend or use meds or something like that. But I definitely see the self part for sure. And I agree. I think it's, I'll speak to the integrative medicine space because that's where I live. It's like that's part of it. And I see that with patients all the time, is when we have that conversation about, what, you're doing a great job. You're doing all the things that are reasonable for you in your life right now, right? Yes, it's not 100%. Yes, things could be tweaked, but you know what? This is reasonable for you right now, and you're doing awesome with everything else going on in your life. And maybe we're not quite there yet, and maybe we are at a point where we talk about medication. And so often I see, their face just drop, like it means like they've failed, or I'm giving up on them finding some, natural approach. And I definitely feel that as a naturopath. Like I feel this sort of self judgment of like, well, I should be super, super healthy because I'm a naturopath and I know all this stuff. And I should be able to handle everything without medication. And I should, and I should, and I should, and I should, and I'm shouldn't all over myself. Right. And so that's, I think about that a lot. And the more patients I see, the more I think about sometimes these narratives feed into themselves in a way that isn't always healthy, right? This sort of like, it has to all be natural. I have to do it all myself. And I tend in that direction. That's why I'm a naturopath. But I think it can go to extremes sometimes and feed off itself and lead to issues. And I just had a great conversation with Allison Seebecker, who's a big SIBO doctor, about this. She's like, tell me about your tough cases. And I was like, the hardest thing is when we don't know what the root cause is, and we've tried so hard and we can't, quote unquote, fix it, and they're at this maintenance place or mowing the lawn phase or whatever we're calling it, and they just look at me like, don't give up on me, doc, right? And I'm like, well, but we do we really need to do another $1,000 test? Like, do we really need to try yet another antibiotic? Like, maybe it's okay to be where we're at. Anyway, and I think it's somewhat related. So I think I'm rambling, but it's on my mind a lot. And it's come up. You and I are talking about this topic today because we've had a lot of conversation about these GLP-1s based on the research and then, news coverage about it. And then we're just seeing in our communities like a lot of shaming around people that are doing GLP-1s for weight loss or for cardiovascular disease risk minimization and things like that.
Yeah, and there's just a few things I want to briefly touch on because I know that we want to get into the mind diet. One area I do see this a lot is when I recommend bariatric surgery to people.
Mm-hmm.
Um, I mean, the data supports bariatric surgery in so many different aspects, and like
Yeah.
people view that as like the ultimate failure when it comes to weight loss, and it's
Right.
not.
Right.
Like, I'm sorry, if you have someone who like qualifies for it, it is a legitimate option to consider, especially with all the health benefits that are associated with it, and to sort of like not at least offer it or to have that discussion, um, I think can be damaging. And it's like, hey, we could do a surgery and you can be on no medications if the surgery works out, and you're tolerating it well. Yes, you're going to hear horror stories from people, but you're also going to hear a lot of success stories as well. And the data supports the use of bariatric surgery for so many different comorbidities that are associated with such a morbid obesity status.
Mm-hmm.
Also, when we think about integrative medicine, I think the issue is people are starting to take integrative medicine and apply sort of this complementary alternative medicine lens on it of it's just contrarian to standard of care, and it's not.
Mm.
In my opinion, integrative medicine is a spectrum that starts from just simple reassurance, which is
Mm-hmm.
also part of conventional care. A lot of times they
Yeah.
are, I have seen just, hey, don't worry about it. Like we really don't need to worry about it. But people are still symptomatic, and so they'll seek other things. So we have everything from reassurance to surgery. In my
Right.
opinion, integrative medicine, the beauty of it and why I became an ND was because we navigate that spectrum. We kind
And
of
I think we
sort
do that relatively well for the most part.
yeah. And I think
Yeah.
you just have to not lose where you are within that spectrum on a case
Mm-hmm.
by case basis and know where you're supposed to be. For
Right.
some, you're on one extreme end of the spectrum where you're maybe prescribing 3 4 medications in one visit and talking about surgery, and then on another case you're just saying nope, maybe we could do some herbal stuff, just like simple diet, lifestyle, work on your sleep, that kind of thing. And I think the issue that I'm seeing a lot of like these integrative medicine programs within larger institutions is they're kind of just boxing it in as like we're just not doing any sort of anything conventional. We're not talking about medications. It's all diet, lifestyle, mind, body, acupuncture, herbal botanical medicine, and that's
Mm-hmm.
it. And in my opinion, that is not integrative medicine. That's just
Yeah.
alternative medicine, right?
But it
And
fits
what we're
within
doing,
the but it fits
yeah,
within the referral framework of hospitals. So like they're like, "Oh, we'll handle this. You guys
hmm
do the other thing." But you're right. At that point, it's alternative, not integrative. Yeah,
hmm
good point.
hmm and especially if it's segmented like that, of like I
Yeah.
am managing this, you are managing that.
Mm-hmm. Mm-hmm.
Integrative is, hey, how's your ibuprofen going for your knee pain? It's helping. Great. Okay, let's get an acupuncture appointment in today or whatever. Now, I'm not
Mm-hmm.
saying that's what everyone needs to do. I'm not. That's not medical advice. That's just sort of like off the cuff example of how you can kind of manage that spectrum within the same visit. And then the last thing I want to touch on too, from a medical shaming standpoint, is the culture component of other non-American cultures where there's a lot of, especially I see it a lot in like the mental health field, of sort of international communities having a tough time or a harder degree of discussing mental health
Mm.
um, outside of sort of, if you grew up in America and you have these sort of US cultural norms, it seems a lot more appropriate to talk openly about your mental health struggles. Whereas in other cultures, it's like, do not bring that up.
I
Or if you're
see.
going to bring it up, you have to do it only on a one-on-one basis. No one else can know. If my, mom or dad or someone in my family finds out that I'm on Zoloft or something like that,
Mm-hmm.
it's going to cause a huge issue. And so I think like
Mm.
that's something that has to be taken into account too, and
Sure.
is a challenge.
That's interesting. So like you could talk about maybe you can talk about stress or something like that. But as soon as you get a medication, that essentially means you've been
You're
labeled with
viewed
this
as like a quote
diagnosis.
unquote crazy person or something like
I
that.
see. Yeah.
It's difficult to navigate.
And so there's like familial shaming or societal shaming there.
Mhm.
Yeah, I mean that makes sense. And I think a lot of this, I don't know about the cultural part because I'm just not educated on that, but from like a naturopathic perspective, which is where I come from, I think a lot of this, and I'm very curious about your thoughts on this, come down to like a religiosity about the medicine. And it's interesting because you get into training and you don't get this in conventional medicine, but you do a lot on philosophy, like the
Mhm.
philosophy of natural medicine, the philosophy of integrative medicine. And so it's drilled in like these like dogma, right? And I think there's value in that, but also it's like it's a little dangerous because you meet these folks that are so religious about natural medicine treatments that to go against it is almost to go against dogma and to go off the path. And so I think that's part of it. And I get worried whenever anyone is so convinced about their position that they're not thinking about everything else. And at the end of the day, like, this is about the patient in front of you and what's best for that patient. Now there's a little bit of a self-fulfilling prophecy in that the patients that seek out, now you're different because you're in like a proper primary care setting, but like the patients that seek out integrative providers specifically because they're integrative providers, like they already, it's self-select, it's a selection bias, right? Like they already have this worldview that they prefer X, Y, and Z. And so a lot of times I worry about, so like that's easy, right? Because it's like, okay, cool, like that's what I know and that's my bent too. But also I worry about reinforcing that to a harm sometimes, where it's like, well, you know what, at this, like we were saying before, at this point, maybe it is time to have that medication conversation. And that doesn't mean you're a failure. That doesn't mean that, natural medicine, quote unquote, has failed you. It just means that at this point in your life, this might be a safer choice for you. And then last thing too, I know we said we'd keep it short, but I just find this topic really interesting is, we were talking about, you were saying like, yeah, doing it all right. Like they're doing all the things. And I would say, even if they're not doing all the things 100%, like, so this is a big thing. Okay. It is true. And we've talked about this before. It is true that if you like cut your calorie intake by like 800 calories, like you will eventually lose weight, or you not eventually, you will quickly lose weight. Right.
Mhm.
But then there's the reality of it and the doing it over a long period of time and the fact that we're all human. So if a plan makes sense on paper and they're like, well, if you just follow this, you'll be fine, but nobody can follow it, or forget nobody, you can't follow it, that doesn't seem like a great plan for you. And that's not saying we shouldn't try and push ourselves and clinicians shouldn't push our patients, but I think there's an issue there too, where it's like, I'll have this conversation and someone will say, well, what if, well, we could tweak it, well, we're missing this, or we're at 95%, we need to be at 100%. Be like, well, I don't know. Anyway, what do you think about that?
There's so much in there that we could go on for hours on this topic. I think to your first point, yes, the second you become sort of religious or dogmatic about something, there's a huge problem there.
Mm-hmm.
And that's why I love evidence-based medicine, is because that's a good checks and balance for it. Now you can
Right.
become dogmatic about evidence-based
I
medicine
was just
and
gonna say, yeah.
only make your clinical decisions based on the evidence. But then that kind of comes down to your latter um, um, point of like, yeah, on paper, here's what the research shows,
Mm-hmm.
but in clinical practice and patient experience and patient values, here's what I'm seeing. And
Right.
so the
That's right.
proper approach to evidence-based medicine is taking it all into consideration and then making the best decision with what you have.
Yeah.
The good thing about evidence-based medicine is that research challenges somewhat irrefutably to the dogmatic religious viewpoints that some people have. So if there are people are having religious views on, let's say, the keto diet, right? And you have several well-controlled studies, meta-analyses, lots of data to refute what they're saying, then that's a win in my viewpoint for evidence-based medicine. So you can't be dogmatic from that standpoint, but I think when you also can't be dogmatic in evidence-based medicine of only relying on the trials and the data, because then you lose the human aspect and the the art nature of medicine, which is a real thing, right? You can be
Mm-hmm.
the most data driven, 100% recite all the trials and know exactly the ins and outs of everything, and if the patient's like, nope, not going to do it, don't care, then it's all for naught. So
Yeah.
you have to be
Yep.
able to navigate that too. And so, I think you can't be dogmatic really in anything. You can't be dogmatic in your stance from a philosophy standpoint. And at the end of the day, it's just a philosophy. It's a framework of mind and thinking. It's not a way that you have to practice. It shouldn't be a way that, like, it's not a religion. Don't become religious in that standpoint, especially if you're managing somebody's health.
Right. Like this isn't like truth with a capital T. It's like this is a useful framework to help patients. And this is all being measured by people getting better. So our supposition is if you follow an evidence-based medicine framework, overall people will do better than if you don't, right? That's the supposition underlying all this. And I really like your point about how, at least how I heard your point, which is that true evidence-based medicine, in my opinion, well, not in my opinion, in like the founder's opinion, like in Guyot's 2008 paper, is about best evidence, physician experience, and patient values. And when it becomes dogmatic, when I see it dogmatic, it's when it's just one of those three legs of the stool. It's in these big hospital systems where they're forcing algorithms on their providers and they're saying this is evidence-based, that you must do this here, and that is forcing the provider's hand on the other two legs of the stool, and then that's what they're told, that is evidence-based, and that is one leg of the stool, right? And so I think when people get dogmatic and upset about the religiosity of it, I think it's when they're misinterpreting it, when it's being, like we've talked about that hijacked paper, when EBM is being hijacked, evidence-based medicine is being hijacked. So I agree with you there. Look, the thing is, we don't do this for money. This is pro bono, and quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential, and there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. Yeah, I don't know, man. Should we jump into the mind?
Let's jump into the mind, Josh.
All right. So hopefully we'll get some listener questions about that. I'd love to continue this conversation. This is another tack. So sometimes we go back and forth between philosophy conversations, which makes Josh happy, and actually getting to real trials and clinical relevance, which makes Adam happy. But now today we're going to just split the ticket, do both in one podcast. So tell us a little bit about the mind trial, maybe some background, and then we can talk a wee bit about it. And we're going to have to wrap up in the next 25 minutes because I got Chinese class.
Oh, geez. Okay. Yes. Let's get into it then. So the MIND diet, MIND stands for Mediterranean dash, and dash is actually spelled out, not like, the hyphen. So it's Mediterranean dash intervention for neurodegenerative delay. So MD. So yeah.
They get creative with these.
Yeah. So the Mediterranean dash is considered the M, intervention is the I, and then neurodegenerative is the N, and the delay is the D, and that's sort of the acronym for MIND. And it's a combination of the Mediterranean diet with the DASH diet. And DASH is the dietary approaches to stop hypertension. That's a very well-studied diet specifically for high blood pressure management using dietary and lifestyle intervention. And so this was a diet where they're kind of blending the two together and trying to see if it can help prevent neurodegenerative delay. And
plus a few other things, right? Like they take Mediterranean, DASH, and then a smattering of other So like anything that there's literature on that prevents cognitive decline, they're like, let's put this together in a diet, essentially.
Yeah, so like high blueberry intake, lots of your dark leafy greens. Basically, they're trying to take, all the sort of observational studies that have been that are showing like, hey, if we have high intake of these polyphenols, chocolate and like super dark chocolate, blueberries, berries in general, healthy fats, your omega 3s, which seem to be associated with improved, you know, improvements in cognitive function, or at least preventing a neurocognitive delay in humans. And we have mechanistic data in animal studies, and now we're kind of adding that to just it's a very, very healthy diet, and basically looking, okay, does this actually prevent anything from a neurocognitive standpoint? And so in the paper, their aims was, quote, we compared the MIND diet with mild caloric restriction with a control diet with mild caloric restriction to evaluate the effects of a 3-year dietary intervention on cognitive decline and brain imaging markers for dementia and Alzheimer's disease in older, cognitively unimpaired adults at risk for dementia because of family history. So it's basically a primary prevention trial where we're taking elderly people, and by elderly, the inclusion criteria starts at 65. So sorry if I offend anyone there, because I don't actually view that as elderly. But they're taking people who are older. They're at higher risk because they have family history of it. And I think that that's clinically relevant because we do, or at least I have seen even younger people be like, hey, my dad or my mom have just got diagnosed with Alzheimer's. Like, am I at risk? Are there labs that we can do? Like, what can I do to prevent this?
Yeah, what diet should I have so I don't turn out
What
like
can I
they did?
Yeah, what can I best do?
Mm-hmm.
What can I best do to not do this, or to not have this, excuse me? And they took this really healthy diet, compared it to a controlled diet, basically controlled for caloric intake, where both were calorically restricted. I didn't understand why they added the caloric restriction. My understanding is there's probably some sort of longevity component to it, or there's some sort of benefit with caloric restriction and neurodegenerative delay. That's likely my guess. And to make things, to make the trial, from a standpoint like actually equal in comparison, they needed to apply the caloric restriction to both. And then it was a true primary prevention trial. They took people who are they're just at risk for it, but don't actually have it. So, right, if you have someone with high blood pressure and they haven't had a history of a heart attack, if we were to give them a blood pressure medication, are we actually preventing the heart attack from occurring? So it's kind of the similar thought process. And they did it over a 3-year period. So a couple
Which is
of
amazing.
thoughts.
Long intervention
Three
period.
years is actually considered long when it comes to dietary intervention. But I think one thing we have to take into consideration is if you're starting at 65 and only doing it over 3 years, and it's a primary prevention trial, unlikely to find, cases of Alzheimer's disease, dementia, et cetera, like actually happen. So I think that that's something that we need to, take into consideration too.
So good point, but it's powered not against cases of dementia, but cognitive decline, which, I mean, they were pretty extensive batteries. I'm assuming, and I don't know this very well, but I'm assuming when they did their power calculations, it was, we can assume this level of change over this period of time.
Yeah, and we'll definitely get into that. And so the trial was funded by the National Institute on Aging, so it was government funded. They registered the trial a priori, meaning before they actually collected data and whatnot. They registered the trial, they laid it out, they said, hey, here's what we're doing, here's what we're looking for, et cetera, et cetera. So we're happy to see that. It was conducted at 2 sites, at Rush University in Illinois and Harvard University. And actually, not too shabby, no. And the way that they actually recruited participants, I actually thought was very inclusive of likely the U.S. population. They just kind of did mass recruiting in 2 sort of large urban settings. So if you think about urban settings are likely going to be multicultural, lots of different types of socioeconomic status, different ethnicities, et cetera, et cetera. And they just recruited them not just through the hospital or through clinical settings, but did mass mailings, they advertisements on radio, subways, newspapers, flyers, et cetera, et cetera. And then they actually did for those who wanted to be part of the study, they did 2 stages of pre-screening. First, it was a telephone interview to kind of just apply the basic inclusion-exclusion criteria just to see if they would even be able to partake. And then for those who were eligible to partake, they actually had them do a run-in phase of 3 to 4 weeks to see, okay, can these people even are they actually going to comply with the dietary asks and the intervention that we want them to do? And they're not taking any sort of dietary supplements that are purported to have cognitive benefits to it, which I think is appropriate because you don't want to run this large, very expensive trial in people who can't do the diet to begin with or are unwilling to comply with the demands of the diet, because then you're not going to be able to understand the treatment effects of the diet. Now, yes, that's not technically externally valid, meaning it's not going to be able to be applicable to the general population because, if you're going to if you're going to recruit people who aren't going to do the diet, then the results are going to kind of tend to the null. But at the same time, if you're recruiting people who are going to be hyper compliant, you're kind of you're going to be kind of trending the opposite way. You might have a bias towards finding a result. But if we don't have people who are going to do the diet, we're not going to know if it works.
I think that's excellent.
From an evidence standpoint.
Yeah, that's a really great summary of the issues with run-in periods. And just quickly to underline one thing there is, like, in clinical practice, if you have a patient that comes to you and you recommend a diet and they come back 2 weeks later and they're clearly not following it, you're going to pivot anyway, right? So I think this is actually quite clinically relevant.
Yeah. And so the mild caloric restriction was only a reduction of 250 calories. And so remember, both groups were encouraged
250 a day, right?
Yeah.
Okay. Yep.
And then the control diet was just their quote unquote usual diet. And they also wanted participants to achieve about a 3 to 5% total body weight loss by year 3. So that caloric restriction was to help to kind of just improve their body weight.
So pretty gentle. You'd lose like a half pound a week or something with something like that.
I think something like that.
Yeah.
I'll jump ahead and just say that
not
both
pushy.
both groups lost 5 kilograms on average. And so that comes out to about 10 to 11 pounds, plus or minus a couple here or there in both groups. So both groups achieved basically the same amount of weight loss. And that's because they're both in a caloric restriction, not because the MIND diet or control diet is better for weight loss. And remember, it's not a weight loss trial. They're just kind of helping support weight loss.
But that's excellent, right? Because now you've taken out the fact of, there's less cognitive decline because they're simply slimmer, right? And they have less cardiovascular risk. Yeah, or the opposite.
Yeah.
Right. If you're underweight. But I guess this was an overweight inclusion criteria. But exactly. So now the only difference, it's not calories, it's literally the quality of the diets that are different.
Correct. And so then they randomized them 1-to-1. So meaning when they randomized them, one person was assigned to the MIND diet and one person was assigned to the control diet. They were instructed to follow the diet for 3 years. They collected data at baseline. So when they first came in at month 6, month 12, and then on a yearly basis. So then at year 2 and year 3, they did cognitive testing at baseline at the 6-month mark, and then at year 1, year 2, and year 3.
Mm-hmm.
And then what I thought was really good was that the cognitive testing was conducted by research assistants who were certified in cognitive testing, which is important because if you're actually going to administer the MoCA, which is a really commonly used cognitive screener in the primary care setting. The Montreal Cognitive Assessment. You actually have to be trained in it in order to like really truly administer it and score it. And so I've gotten the training on that. It's pretty easy, but
is it very different than how we were trained as school? Because I've done a zillion MoCAs, but I never had like straight up MoCA training, like within clinical training.
No, it's not all that different, but the training is interesting, and they do want you. I think that from a data standpoint, they find that it's better if people are trained in it to
more
get
standardized.
More standardized. So these people who are administering the cognitive testing were trained in it, they were certified, and they were unaware of assignments. So that's good. And then so the dietary counseling was done by telephone each week for the first 6 months, then every other week for the next 6 months after that, and then at least twice a month during years 2 and year 3. So they're having pretty heavy dietary counseling to help with adherence.
Nice.
Foods that were part of the MIND diet that were considered lacking when they were doing dietary recall with participants were encouraged to actually increase the consumption of those foods that were lacking. And then for people in the control group, they just kind of really re-emphasized portion control and maintaining that caloric deficit. And both groups kept their exercise levels at baseline.
So really nice, even comparisons here.
Yes. And then, so that they're doing great comparison, really intensive, healthy dietary lifestyle coaching stuff. The MIND diet kind of had a subsidy where a nonprofit food organization was giving them food each, basically a monthly supply of food. They were getting 15 ounces of blueberries every week, 5 ounces of nuts every week, and 14 tablespoons of olive oil per week. Whereas the control group was just given $30 at the same frequency of the MIND diet. And they could, I guess, do whatever they wanted with that money. And then both groups had 5 opportunities to sort of like mix and mingle with each other within their group. So people in the MIND diet could talk to other people in person that were part of the MIND diet, and then same thing with the control group. At month 3, 9, 18, and 30, I think that's important because there is a social component to the Mediterranean diet. If some people think, is it the diet or is it the social aspect? Is it all that? And they were talking about during those it's not like they're just getting wine drunk at those sessions.
That's how I view the Mediterranean diet.
Yeah. They're talking about diet, tips to promote weight loss, motivational activities, cooking classes, trivia games, stuff like that. And
they did a good job in this design, huh? Yeah.
And then to also make sure that they were actually making those dietary changes, they looked at biomarkers of like key dietary components. So they looked at like carotenoids, beta carotenes, et cetera, and those should go up if you're actually adherent to a diet that's high in those. And
that's important because the questionnaires for diets are notoriously inaccurate, and they're inaccurate not across the board, but they're weighted in particular directions. So having those biomarkers support that they really are changing their diet is huge.
Right. And then in order to actually be included in the trial, you had to be at least 65 years of age, score higher than a 22 on the MOCA, because we don't want people who are already having, cognitive issues. Yeah, we want people who from a cognitive standpoint are healthy, because again, it's primary prevention. We want to see, is this preventing cognitive decline? They wanted people who are overweight, and I guess that was viewed as a risk factor, and people who had a primary relative, meaning mom or dad, not like, oh, my dad's uncle's, third removed cousin had Alzheimer's. They wanted someone who had actual Alzheimer's in their family. So like mom or dad was diagnosed with Alzheimer's, and they had to have a suboptimal diet, which was considered a score of
suboptimal MIND diet.
Yes, correct. Suboptimal MIND diet. So basically, and I don't know if they actually like verified the MIND diet in another trial or anything like that. So there's some questions here of basically they took the MIND diet and said, okay, here's a cutoff as to like what is considered quote unquote healthy.
Or this is considered the MIND diet. So like if you're already doing the MIND diet, there's we don't want you in the study. Like you have to not be doing it, and then we tell you to do it, and then we see what happens.
Yeah,
exactly. You could have a very healthy diet, but if it's not the MIND diet, you can be included.
Yes. And so they actually, I think they did 12 different cognitive function testing, or 12 different cognitive function tests. And the primary outcome was basically they took all those 12 cognitive functioning tests and smushed them together to create one score. And they standardized that. And there's statistical methods for doing that we're not going to get into. But basically, those 12 tests were broken down by episodic memory, semantic memory, executive function, perceptual speed. And then, you can kind of score across all of those for individual scores. But what they were interested in was basically a composite score of all of those. So okay, what happens if we smush them all together and evaluate the change in score on that on a standardized basis? So if you think about like your SAT scores, right? You can score a max score of like, let's say, I don't know what it is now. Let's say 2000. but within that, maybe there's like math, science, language comprehension, whatever, and then you can kind of subcategorize it. But your composite score is that total SAT score. So that's kind of the same thinking here. And then they also looked at those individual episodic memory, semantic, executive, perceptual speed scores on their own. But really, the focus and the way that the trial was conducted and powered was for that global composite score. And then secondary outcomes looked at changes in MRI brain findings between baseline and year 3, specifically looking at total brain volume, hippocampal volume, and the volume of white matter. Was a secondary outcome. We're not going to focus on that because the paper did not actually look at multiplicity testing, and we talked about that in our last podcast. And so if you're interested in that, I recommend that you, or not our last podcast, but the one before that, if you're interested in learning more about that, go back and have a listen, because we do talk about the importance of that. And we don't have the time right now to rehash all that, but basically we can't take any sort of, we have to take all the other results with a grain of salt if it's not this primary global composite score, because they didn't do multiplicity testing, and they didn't power the trial for the secondary outcome.
Right.
So what do the results show?
Drum roll, please.
Yeah. 2,000 people were basically screened, of which 69% were excluded for various reasons. And ultimately, they had 301 in the mind diet group and 303 in the control group. And that actually met the power calculation. So they had an adequate number of participants to find the results that they wanted to get.
That they expected they would see. Yeah. Mm-hmm.
Yeah. And they only lost 9% of participants in the mind diet and 5% in the control group. And so that's over a 3-year period for a pretty rigorous dietary intervention. That's really, really impressive.
Through COVID.
Through COVID.
Outstanding.
And I can do a Dr. Journal Club video on this if people want, and kind of get into the more nitty gritty details as of some more of like the stats and some of the methodology. But so far, everything is pretty healthy and clean. We're loving what we're seeing.
It looks really good. It's a good study. Really good study.
So in the mind diet, they started with 301 people, ended with 275. In the control group, they started with 303, ended with 289. Very impressive, given the fact that it was a diet trial over 3 years. Both groups are similar at baseline, and only 6% of the planned cognitive assessments were not done. So out of the 3,000 plus tests they did, they only missed 170. And that likely is mostly due to the people who dropped out of the study. So that's also great. The mind diet scores at baseline in the mind group was a 7 plus or minus 2. And then in the control group was also a 7 plus or minus 2. But what we saw in the mind diet was that score of 7 jumped up to an 11. And in that control group, a great improvement. And in that control group, it went from a 7 to an 8. So
both groups improved.
Yeah, both groups improved, but technically that control group, they're kind of meeting that mind diet criteria. So you can kind of ask the question, is it really an adequate comparison? Is the mind diet now being compared to just a lesser version, but still the mind diet? Or are we actually comparing mind diet to a suboptimal, or does it not matter? Is there this continuous outcome where better mind adherence, or a higher mind diet score, does that mean you have better functioning or more of a robust effect? Or is it dichotomous in the sense of like less than 8, no effect, greater than 8 will have an effect?
Wait, you're saying at the end of the trial? So I'm looking at the baseline characteristics.
Correct.
And they're about equal, just under 8. But you're saying at the end they both groups went more towards mind?
So at the 6-month mark, the mind diet group went from that 7 to an 11, and then maintained that throughout the rest of the study. The control group went from a 7 to the official stat was 8.5. So they're actually technically above that 8 threshold at the 6-month mark, and then maintain that throughout. So now you're
But they started, so granted, but they started at 7.8.
Yes, so it's very minimal improvement. Yeah.
Yeah, so they really didn't shift their diet much, and so we're quibbling over the fact they went from they crossed that 8 threshold, but they really didn't change their diet much, 7.8 to 8 point whatever, right?
Okay, so we'll take that. Like I said, from a weight standpoint, they both lost basically the exact same amount of weight, on average about 11 pounds over the course of 3 years, and that ranged from 9 to 13 pounds, so very precise results there. Okay. Primary outcome. Again, this is looking, and they had to standardize it so that it's kind of a funky way of explaining it. We have to view it as standardized units where, every 1 point change in the MIND diet would change that composite score by this number of units. And there was no statistically significant difference between the two groups. The mean difference was 0.035 standardized units, which was really quite depressing. Yeah. And then there are also
I was rooting for it too. The whole read.
Yeah, and there was really no changes in the MRI findings as well. But again, can't really make anything of that. I think it was interesting. Yeah, in the discussion, they said, previous meta-analyses really kind of didn't show any benefit effect on diet and cognition. And then they also found the same thing, in this trial. And, they basically said that a couple of things that could take into account was that maybe repeat cognitive testing, you learn the test as a participant because you're doing the same tests over and over again, may have contributed to this null finding, and that's been shown in other randomized controlled trials.
Well, no, that it would explain the improvement from baseline, but both groups would have improved, and so the difference would be attributable to MIND. So I don't think that could explain the null finding, but it could explain the improvement from baseline.
And that's why we have you on the podcast. And then they also said, well, maybe there's just diet just doesn't do anything. And I think
which is the primary conclusion. Well, no. So assuming it's not just learned behavior that they improve from baseline, the other take home is like caloric restriction improves cognition in people who you would assume normally would lose cognition over 3 years because they're at high risk. So that's pretty cool. So if it's not just the learning behavior of taking the test over and over again, and also the MRI didn't worsen, right? So at the very least, I mean, like you're right, it's underpowered, but yeah. Anyway, so null findings that maybe we could explain in different ways, but yeah, I was kind of bummed. Alrighty, we're gonna cut it here, everybody, and thanks for listening, and we'll see you again next week.
Have a good one.
If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media at Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.